Okay, thank you, Ava. Thank you for setting this up and moderating for us. Uh, for those who are online, thank you for joining us. Those who are new to this conference, it's a virtual slide conference that we have once a month. That's hosted by the Diagnexia Laboratories, and thanks to Ava Carr, who organizes and manages this for us. And what we do is look at cases that I've scanned, digitized, and share with you. I will show you the morphology, describe it to you, and then we have a chat group where you can put in your differential diagnosis, your investigations, your questions, and we'll try and answer all of them as they go along. So feel free to tell me what you think as we go along. And the success of the meeting obviously is based on your input so that we can have a conversation on that. And the chat is probably the easiest way to go. So without much ado, let's start with the first case. This is a groin mass in a 54-year-old male. And the history was that he had this groin mass for 7 years. This was removed by a sarcoma surgeon because it was a groin mass. But before removal, the surgeon performed a biopsy, and this is it. So there's several cores. Let me just show you the entire picture. Several cores. We can go to any one. This seems to have the most or the best representation. You can see nests of these cells. Okay, trabecular pattern. Some even had some cords, and here as well. You can see this pattern here, almost single filing. Okay, so just to repeat the history, if you came on just now, 54 male with a groin mass for 7 years, and this was a biopsy from the mass before surgery. This was eventually resected, but I want to know what you think on the biopsy. Any investigations that you'd like to do, or what is your differential diagnosis? Let's see. Okay. So far, people want more context or morphology. Let's look at other areas. It's a little crushed on this side. Let's take another core. Okay, predominantly trabecular and cords. Anybody have any thoughts? Yes, Kumar, yes, metastatic carcinoma is a good thought. Let's start off with that. Joanne, carcinoma differentials includes prostate adenocarcinoma, 54 male. Surely, certainly we'd include the prostate. Any other thoughts? Okay, so it's diffusely epithelial positive. So the keratins are positive and epithelial it is, and morphology, as you've pointed out, that it looks like carcinoma. Any other thoughts? Any other stains? You can see this almost single filing here as well. Any other sites of origin that people think this may be coming from? Synaptophysin, Irene, yes, synaptophysin positive. Kumar, breast, correct. Synaptophysin was positive. And when I do neuroendocrine markers, I may have indicated this previously, I always do all three endocrine markers, neuroendocrine markers. I do the synaptophysin, chromogranin, and the INSM1. Synaptophysin is sensitive but not that specific. Chromogranin is specific but not that sensitive, so it's usually very focal. And then INSM1 is a nuclear marker, which is very useful to cap the role. I never do CD56, so just to get that out there. Yes, Kamal, I also thought breast, and I did all the breast stains as well. And you guys know the breast stains, mammoglobin, GATA3, were all positive, including ER was also positive. So based on that immunohistochemistry and neuroendocrine markers, how would you sign this out? Right? So what I did was I called the surgeon, and I said to surgeon, this looks like a breast carcinoma. Can you palpate or examine the patient? And the surgeon came back and said, no breast masses. And in fact, there was some radiology as well, and that did not show any breast masses. So breast was out, and it was back to the drawing board. So we signed this out as carcinoma, and we had a differential diagnosis of possible metastasis. But there was also a paper that my colleague Tom Hu found in Modern Pathology, which is abbreviated as SCAND, and that's in Modern Pathology. If you Google that, the paper will come up. Modern Pathology. SCAND. So that stands for sweat gland adenocarcinoma with neuroendocrine differentiation. SCAND. It's a paper, I think it was from a Japanese group, and described this identical tumor with identical morphology and identical immunohistochemistry. Both the breast markers are positive. But you know that the breast markers are positive in sweat gland carcinomas anyway, because if you look at the breast and sweat gland, it's just modification of the same epithelia. And so the surgeon did a wide local excision, and as far as when I last checked, the patient was still well, but I haven't checked recently. So SCAND, sweat gland adenocarcinoma with neuroendocrine differentiation. And of course, you always have to rule out metastasis, and that's easily done these days in radiology with a PET scan to rule out any possible primary sites. Any questions or comments on that? Okay, let's go to the next case. This is an interesting one. If you like GYN, this is a pelvic mass, female. I don't have an age for some reason, but this was in the pelvis, and it was 11 centimeters. And not sure where I got this from. Maybe an in-house case. But here we go. There's a nice section of this tumor. It was well circumscribed on radiology. And I'm going to go down just to give you a medium size view of these. These structures that you see here, all vessels, you can probably see some blood in some of them. And then the background, what I think is more sort of edema rather than myxoid. You may disagree, but be that as it may, let's just look at the vessels. Here we go. There's some vessels here. Just go on high power on these vessels. Okay, so you can see that it's very hypocellular tumor, very scant and hypocellular. But this looks more myxoid here. It's got that material. You can see these spindle cells, very scant and few and fine between, largely separated by this myxoid material. Near the vessels, collection of vessels, spindle cells. And here, let's see if we can find more spindle cells for you here. There we go. Okay, very bland looking spindle cells. And here are the vessels. Higher power of the vessels. Just to give you a close look at these. You can see they're thick-walled. Some of them medium-sized, some are small. So and some are very small. You can see the capillaries here. And so there's a varying size of the vasculature. It's not a uniform appearing. Okay, so circumscribed pelvic mass, 11 centimeters in adult woman, adult female. I don't have an age. Okay, let's see what people have thoughts on this one. Aggressive angiomyxoma, of course, Janice. Yeah, you have to Miruna, deep aggressive angiomyxoma. Yeah, that was changed. The name was changed from aggressive angiomyxoma. I think in the last, or perhaps the iteration before that, WHO changed from aggressive angiomyxoma to deep because it was thought that they're not that aggressive. Now, the key feature that I gave you was this was well circumscribed. And the aggressive angiomyxomas are not well circumscribed. They're infiltrative, and that's the surgeon who's going to tell you this thing is deeply infiltrative, but very bland, a lot of myxoid, hypocellular. You can get bands of smooth muscle, and a subset of them do have a molecular signature of HMGA2, which you can look for as well. Yeah, Janish, correct. This is circumscribed, so that helps you rule that out. So yeah, yes, Mirona, differential would include that, but given that this is well circumscribed, immediately takes out the aggressive angiomyxoma. Dora, angiofibroma. Yes, I thought that would come into the differential, the cellular angiofibroma. Well, this is firstly not very cellular. It's got a lot of myxoid material and edema, very sparsely cellular. Cellular angiomyxoma has a lot more cells, a lot more spindle cells, also very bland, but the vessel size are very small. So in a cellular angiofibroma, I'd expect this size of vessels with the hyalinized. So that I don't know what that's artifact, but that's what I would expect a cellular angiofibroma to have, vessels that size with hyalinized walls. Okay, purely homogeneously hyalinized walls. The cells are CD34 positive, and they have RB1 loss, and of course ER is positive in those as well. So morphologically, although it's in my differential, cellular angiofibroma in my differential, so is aggressive angiomyxoma in my differential, or deep angiomyxoma. On morphology, I'm happy to rule those out based on the fact that this is much larger, it's well circumscribed, has a varying population of vascularity, right? Varying population of the size. Some of these are tortuous as well. Let's go back and look at these. Okay. Let's see if there's any other thoughts. Any other? Okay, we got, yeah, what about massive edema? So massive edema of the ovary would be in the ovary, and this we were given to understand was not in the ovary, it was in the pelvis. So that was the helpful. Yeah, variant torsion and stromal. These are all good thoughts. These are thoughts that you have to think about and speak to your surgeon. And of course, the surgeon will clearly, very quickly say, no, the ovaries are normal, and this is not in the ovary. So those are all good differentials. Superficial angiomyxoma. Well, that's the opposite of the deep angiomyxoma, isn't it? Of the aggressive angiomyxoma. Those are usually in the dermis. They're lobulated. They may have entrapment of skin adnexal if it's in the skin vulva side of it. They may even have some neutrophils. Also very sparsely cellular. And you could take pictures of this on high power and say this is from a superficial dermal lesion. And you know that is what you'd call it, a superficial angiomyxoma, but they're not always so superficial. There was a paper I think it was HistoPath a couple of years ago where they showed these deep in the breast, and the breast angiomyxoma, or maybe American Journal of Search-Path. The first author is Esther Baranov. I know that because Esther is a colleague, who joined us a couple of years ago, and she wrote that paper. So you can get angiomyxomas in the breast. That was with Dr. Fletcher. Edematous angioliomyoma. Yeah, of course, Georgiana. Some sort of. You have to think about that. Remember the leiomyomas of the uterus can sometimes have edema, can have water, and they can have hydropic changes as well. So, but this is outside of the uterus. You can get smooth muscle tumors outside of the uterus. I accept that in women. In fact, the peritoneal cavity is a secondary Mullerian system, if you think about it like that. So all the tumors you get in women in the GYN tract, you can get in the Mullerian system as well. Edematous Genesian odd IMT, inflammatory myofibroblastic tumor. If you think that, do the ALK. I always say, if you're thinking about IMT, the best way to do it, because the morphologies can vary. In the early days, they're more myxoid, and then they become more cellular, and then in the late stages, they become more hyalinized. So if you think of that, you can do that. Any other? Did I miss anything? We talked about the aggressive angiomyxoma. We talked about the cellular angiofibromas, superficial angiomyxoma. The only other two, yes, Mirona's hit the nail, angiomyofibroblastomoma. So the only other two are one angiomyofibroblastomoma and myofibroblastoma, extramammary myofibroblastoma. So the way I distinguish between that is the extramammary myofibroblastomas are CD34 positive and Desmond positive. Okay, this one was CD34 negative, but Desmond was positive. So let me show you. I'm going to go back to the slide and show you why I was concentrating on these vessels. So you see these smaller plumpish spindle cells. They're not that spindle, but they're a little more plump. Okay, faith, eye of the beholder. But these are Desmond positive, and these are around the vessel. And that pattern was recreated around all the vessels where you saw these Desmond positive plump. If you read the books, they call them epithelioid. All right? You go to the books, they're epithelioid. So in the varying size of the vessels, these plump epithelioid cells, perivascular, that are Desmond positive, plus ER positive, and then of course RB1 is retained in these. RB1 is lost in myofibroblastoma and cellular angiofibroma, just to stay with the GYN mesenchymal tumors. But RB1, yes, I did call this an angiomyofibroblastomoma. So it's edematous and myxoid, and that's exactly what I called it. So yeah, it's good just to talk about these genital tract. I don't call them lower genital tract anymore. I used to, because this is in the pelvis, so this is not even in the lower genital tract. And I've seen angiomyofibroblastomas and cellular angiofibromas occur in the pelvis, but not necessarily in the external genitalia. So I call them just genital tract mesenchymal tumors. And I used to call them in the female genital tract. And again, that's changed over the last several years, because you can get any of those tumors we talked about in men. So you can get them paratesticular, inguinal canal, and we see them even in the upper thigh. So you can get these as well, and you can see they go all the way up to the pelvis as well. I hope I'm pronouncing this correct. Gion Dietnet, is edema common? I've seen them. I've seen edematous ones, and the answer is no. But here, the Desmond positive epithelioid cells retain their perivascular distribution, which helped me. The I saw one a few months ago, which is probably in one of my later slide seminars, with excessive amount of fat and just islands of these vascular components and Desmond positive, and it was a sort of like a fat-rich angiomyofibroblastomoma. So, you just have to do your stains, and the one we've talked about already in this context would be ER, estrogen receptor, RB1, CD34, Desmond. Those are the sort of 4-5 that I like to do as a starter, and then work around the morphology and use that. Dr. Oh my God, I'm missing her name in Brigham and Women. She's written several reviews on these genital tract mesenchymal tumors. So you do get a lot of overlap. You have to look at each case in its own context. You get overlap with the stains. RB1 is difficult to interpret in the best of times. They really don't work that well, and people I've talked to always have problems with retinoblastoma gene. So just look at each case in context, size, circumscription, and then the morphology, and work around that. Okay. Any other questions? Did we leave anything out in that? Okay, let's move on to this shoulder mass 23467, 23468. Sorry. How about this shoulder mass 4.8 centimeters? This patient is 57, female, so almost 5 centimeters shoulder mass, and this is the resection. Again, fairly decently well circumscribed, but don't pay much attention to that. It's sort of almost a pseudo capsule there, and you can see that I'm showing you a medium power here, just to show you these areas. Okay, I'll give you a better. Let's just go to. Yeah, this probably also reflects. I think this is probably nice. Yeah, this just to show you these areas here. Okay, I'm not describing them, but those look very myxoid to me. Those look very myxoid. This looks more fibrotic or sclerotic. We'll come back to these more cellular areas here. And there's more areas here. I'm going to show you these areas. Let's see what the chat is saying before I go any further. Any thoughts? Not seeing anything. Shoulder mass 5 centimeters. Well, I'm rounding it off in a 57-year-old woman. Okay, let's go back to these areas here. They use that term marble-like in nerve sheath tumors. It reminds me of that now as I look at this. Okay, it sort of almost has that marble-like pattern. But the S100 SOX10 is negative before you ask me whether this is nerve sheath tumor. So what we have is these alternating areas of myxoid and fibrosing or sclerosing areas. Okay. See if there's anything in the chat. Okay, we are going. Yes, Miruna, you got your MUC4. It's positive. MUC4 is positive. So Irene, myxofibrosarcoma. It's a good thought. Very good thought. And myxofibrosarcoma, remember, has to have pleomorphism, nuclear pleomorphism. This looks pretty bland. The nuclei look pretty bland. And in order to make that diagnosis, you have to start off with alternating lobules of myxoid stroma alternating with areas that are fibrotic and fibrosing or sclerosing. And you have to have atypia. And then, of course, your curvy linear vasculature, pseudolipoblast, all add to that as well. Low-grade fibromyxoid sarcoma. Low-grade fibromyxoid sarcoma. Come on, you want to add myxoid, MYXOID sarcoma to that. Janish has written it for you. Yeah, So it's exactly it. And and we did the FUS gene, which, as you know, fuses with the CREB3 L L2 gene. I think it's, yeah, CREB3L2, which is, I think, on 7, FUS is on 16. Doesn't matter. I don't remember those. Don't quote me on that. But yes, the FUS is rearranged in this, and the MUC4 is positive. Now, that's the easy part. That's the easy part, guys. All right. What about these areas? So we accept these as low-grade fibromyxoid sarcoma, the alternating areas of myxoid and sclerotic. Cellularity does look a little too much here as well, but then very subtle and intermingled within these areas. You see areas like this, still spindle, some of them a little more epithelioid, and not the best that you can see. But you can see this sort of sclerosing areas here as well. Not the best. And then these more higher grade myxoid areas. And again, not the best as well. Any thoughts on that? Yep, correct, yeah. Okay, Batul, I think you wanted to say dedifferentiation. I'm not aware of the low-grade fibromyxoid sarcomas undergoing dedifferentiation as such. By definition of dedifferentiation, like the solitary fibrous tumor can undergo dedifferentiation, the well-defined liposarcoma can undergo dedifferentiation, and so on and so forth. But these, to my knowledge, do not. But what they can do is transform to a sclerosing epithelioid fibrosarcoma, like Dr. Jetnet has pointed out there. I hope I'm pronouncing that correctly. Sclerosing epithelioid fibrosarcoma. So this, in fact, is a hybrid low-grade fibromyxoid sarcoma with sclerosing fibrosarcoma. These areas here demonstrate that quite nicely. And FUS was rearranged with. We did not do the partner here, but typically FUS would fuse with CREB3L1. The sclerosing epithelioid fibrosarcoma would typically have a fusion between EWSR1 on 22 and chromosome 11, which is CREB3L1. So and then again, you can fact check me on this, but the hybrid ones, to my knowledge, tend to be more sort of FUS CREB3 L2, which go on to SEF, sclerosing epithelioid fibrosarcoma. But just double check that on that hybrid fusion analysis. But this was nice. Let's see if there's a. This was just a nice hybrid low-grade fibromyxoid sarcoma with sclerosing epithelioid fibrosarcoma within it. And these look a little more sort of less cellular. Arcades of vessels that are described in these low-grade fibromyxoid sarcomas. Even these areas are a little too cellular for just a typical low-grade fibromyxoid sarcoma. This probably is more the cellularity that you'd expect in low-grade fibromyxoid sarcoma, very hypocellular. And then, of course, you can get those giant rosettes, which, we hardly see. But the older literature in the early 2000s talked about it being about 30 or 40%. Those were the days I used to go and search for those giant hyalinizing rosettes when we did not have MUC4. But now with MUC4, it's much easier. Okay, any questions on this? How do you report the parameters? So I use for the grading would be the French FNCLCC system grade 1, 2, and 3. This would obviously be high grade because sclerosing epithelioid fibrosarcoma definitionally is high grade. So I would report on the high grade features. And the parameters, obviously, size, mitotic figure, necrosis, and atypia, according to the FNC-LCC grading, the French grading system. Is that what you asked me to? Just use that system for this. Okay. Clearly, the sclerosing epithelioid fibrosarcoma is going to determine the prognosis and outcome. No, 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 Janish, it's not. It's not. That's a good question. Now you have to check because I haven't thought about this in a while. But you can get MUC4 in other tumors as well, and you have to be careful. I think myepitheliomas can be MUC4 positive. The ossifying fibromyxoid tumors, OFMTs, can be MUC4 positive. So be careful. And then more recently, there is a paper. Let's see, Maroon. I just need to see MUC4 is not spelled. There's no expanded. Yeah, correct. Yeah, the MUC4 fibroblastoma, which was described uh, a year or two ago by the Brigham Group. Dr. Hornick described that, and then more recently there was a larger series. I want to say from Japan. This year, there's another series in Japan as well. And of course, yeah, the FET Krebs rearranged mesenchymal tumors can be MUC4 positive, but those tumors can have a very wide immuno profile, which is often very confusing, and then that apparently should alert you to the FET Krebs rearranged mesenchymal tumors. Uh, yep, thanks, Miruna. Tumor is hybrid, so you give the whole size. Yes, the whole size, correct. It's difficult to separate which is the ugly bits and which is the low grade bits. So yeah, you just measure the whole thing. Janish, Miruna also. Synovial, yes, yes. I'm not come across that with MUC4, but I believe you. I probably would never do a MUC4 in a synovial sarcoma, nor an alveolar rhabdomyosarcoma, but in context, I think the one that you have to be careful for are the OFMTs. You have to be careful. Those can be Desmond and S100 pos, which is helpful as well. And then the MUC4 positive fibroblastoma. That's a scary one. They can have myxoid areas. The fibro, they're large. They occur in the extremities, and they can have myxoid areas within them. I think that's the one you have to be cautious about. Yes, thank you, Miruna. Yeah, those. No, I believe you. I'm not questioning that, and I did come across that as well. But the point being, if you're seeing something more sort of epithelioid and alveolar, rhabdo muscle-like, you'd go the morphology first. Okay. So with synovial sarcoma, myepithelioma, yeah, that can come into a pitfall. There's so can OFMT and so can the MUC4 fibroblastoma. Those are the ones you have to be careful about. So point being, if you have the MUC4 fibroblastoma, you'd need to do a FISH for FUS before you sign that out. I had one last year, and this was just before that entity was described, and I saw some MUC4 positivity. But when we did the FUS, which was negative, we even did the EWSR1, which was also negative, just to be sure. And my colleague, Dr. Zhang, who does the FISH, I think he also has the Krebs genes as well. So anyway, be that as it may, I think the MUC4 fibroblastoma, MUC4 positive, that's the one you have to be cautious about. You need to do a FUS on that one. You need some molecular negativity to call it a MUC4 positive fibroblastoma. And then, of course, if it's low-grade fibromyxoid sarcoma, you'll need FUS gene rearrangement. So that's the one to be careful about. Myepitheliomas can come into that differential because they can be myxoid as well. But then again, you'd hope that the keratins and S100 and other myepithelial markers would be helpful. P63, SMA, and calponin. So you'd hope those would be helpful. Bearing in mind that 50% of myepitheliomas in soft tissue are EWSR1 rearranged. So be careful of that. We just said the SEF, sclerosing epithelial fibrosarcoma, can also have the EWSR1. Yeah. Okay. I think she wrote a review as well, Miruna. Dr. Fritchie. I can't remember where I saw that, and she does mention all of these MUC4 positive tumors as well. Yeah, that's good. So MUC4 is not specific to answer Janish's question. Yep. Thank you, guys. That's all good. All right, all right. It's just good conversation and good revision. Makes me think about things as well. Let's see, what else do we have for you? Let's go back to my slide and jump to 627. Here we go. Okay, how about this one? This is a 93-year-old male, and this was in his left dorsum hand. This came in as a consult from one of our colleagues in the surrounding greater Philadelphia area. You can see the skin, okay, and you can see this very well circumscribed nodule. And I'm going to go and show you what it looks like. I recently had one in the thumb, maybe about a month ago. Identical morphology. So here we go. Here we go. You can all see the giant cells quite clearly. Stromal cells, little spindle, little plump. And then this bloody sort of background here seems to be a feature of this. Okay. No mitoses that I could find, but whenever I look at these cases with you, I always find something unusual. Okay, so more sort of fibrosing areas there. I don't think that's osteoid. It's sort of fibrillary, more fibrosing areas. This seems to have more of the stromal areas. These giant cells, to my eye, look more sort of osteoclast-like rather than the true giant cells that we see in giant cell tumor of bone. Yes, some of these do look. Some of them do have more nuclei. You can see that here. Okay, let's see what people are thinking. Giant cell rich histiocytoma, tenosynovial giant cell tumor. Yeah, tenosynovial giant cell tumor clearly comes into that differential. Yep, and those tend to be more lobulated. They tend to have a sort of secondary inflammatory transit, as they call them. Keratin's negative, Miruna. What are you thinking about there? Thinking about the xanthogranulomatous epithelial tumor, right? CK7 and A1A3 are positive focally in that. Keratin was negative. Yep. Keratin, reparative granuloma of skin. I've come across that in the jaw, medulla, but I don't do skin pathology, so I'm not going to comment on that one. You know better than I do. So giant cell tumor of soft tissue. Irene, yeah, Sheena, that's giant cell, xanthogranulomatous giant cell. Those tend to have keratin as well, so they sort of epithelial tumor. One of my colleagues, Karina Dana, wrote a paper on that, I think in Modern Pathology. Nice series of that. Exoskeletal giant cell tumor. Maha. I don't know if they call it exoskeletal, but we did do the G34W because that's, as you know, is a good marker for H3F3A feature of giant cell tumors of bone. That was negative, yeah. Epithelial markers were negative. S100 SOX10 was negative. That Miruna, that soft tissue, giant cell tumor of soft tissue, which is what I call this eventually, having ruled out all of the others. Remember tenosynovial giant cell tumors, you also see the stromal cells, which are synoviocytes. They can be focally Desmond positive or clusterin positive. We don't have clusterin, but if you read the papers on it, they also focal clusterin positive, and they also have these cells which have iron pigment in them, and cytopathologists call those ladybird or ladybug cells. I guess if you come from the UK, it's ladybird, and from this side of the pond it's ladybug. But anyway, this did not have any of that. And I was talking about the uh, the inflammatory. Remember that in tenosynovial giant cell tumors, CSF1 is upregulated, uh, and that's a colony stimulating factor, which has the ability to attract lymphocytes and foam cells and mononuclear cells, histiocytes to that. And this doesn't have any of that. Doesn't have any of that. And also, it's not sort of lobulated. You may argue it's vaguely lobulated. Uh, you could, but they tend to have these hemorrhagic areas as well. It's very quite distinctive. Um, so there you go. Yeah, giant cell tumor of soft parts. That's what I call this. And of course, given his age, he is what 93 years old. It's like leave the guy alone, right? Uh, Given his age, you'd want to rule out metastasis as well, which is important. But you'd expect to find mitotic activity and more pleomorphism in that. This is very well circumscribed. But I did put that in my comment. Remember that you can get these osteoclast-like giant cells in a number of tumors, and the ones that come to mind, you guys probably know more about these than I do. The ones that come to mind are breast. Yes, they are circumscribed, just to answer your question there, John. Breast can have osteoclast-like giant cells. Lung can have osteoclast-like giant cells, adenocarcinoma of the lung, and GY. And I've seen it in the GY and endometrial adenocarcinomas myself as well. And there's a few pancreas. That's the other one. Pancreas can also have, and so can bladder. So, I put that in as a sort of covering potential metastasis from these sites, and that would at least validate and contribute to them doing a PET scan to just rule those out. But yeah, I call this a giant cell tumor of soft parts. They're very rare, and was the one I had a month ago. I show we have a weekly consensus conference, and talked to Dr. Dane, and she said they've not yet shown any molecular signature for these, although they should, and hopefully they find them. Yeah, they circumscribed. Uh, Miruna, yeah, that's the old MFH. That's the old MFH, malignant giant cell tumor of soft parts of tissue there. Those are all historical, but yeah, we now call them UPS. There was also the inflammatory MFH, and so on, so on. But those have all been decriminalized, if you will. So, that most of them now, fall into categories that we recognize, particularly the immunohistochemistry. Now more so with molecular characterization, you're able to characterize these even better using molecular. And then, of course, having ruled all of that out, you can then call it a UPS. Our oncologists nowadays, when we sign out cases, morphological line diagnoses with immunohistochemistry being negative, maybe FISH for MDM2 being negative. And then, of course, we say to further characterize, you can send it off for next-gen sequencing. But they're often keen to know whether it's UPS, because now there's a particular immune inhibitor for UPS, and they like to know if you think this is UPS, then they're going to start the patient on that. So things have taken a turn, and UPS is no longer that sort of waste basket. So things are evolving, and then of course you probably want to know the history of this, but it goes back to the early 90s. It was Dr. Fletcher who sort of unraveled the mystery of UPS, challenged it, and then I use the word decriminalize because many of them turned out to be sort of things like leiomyosarcoma sarcoma and myxofibrous sarcoma, and even a whole slew of tumors. About 60% of them were characterized purely on immunohistochemistry. But now, the oncologists like to know if it's UPS so they can start patients on this therapies. Okay, that's just a little bit of that. Do we have time for another case? Maybe, yeah, we do. It's 1:50 on my side. Before I forget, and if I don't remember, Ava will send out an advert email for August 5. Okay, next meeting, August 5. If you have friends who want to join, just send them that email. They'll register with Ava. Okay, so that's the easiest way to do it. Let me show you this last case before you go. Something that you can chew on. No, wrong field. The number here is 431. 431. There we go. Here we go. 431. Left biceps 3.6, 34 male. So here you can see the soft tissue around there, poorly circumscribed. Okay, you can see it extending around periphery into soft tissue. Just here, this is sort of more fascial planes. You can see this fascial tissue here as well. Okay, and then here's the tumor itself. Little myxoid areas, spindled, ovoid, more myxoid areas. How about these areas? Some bone, more cellular areas, more bone. Okay, so poorly circumscribed, alternating areas of myxoid spindle cells, ovoid cells, short fascicles. Having said that, this looks longer than a short fascicle, and some bone as well. Yeah. So just to repeat, left biceps 3.6 centimeters, 34 female. Oh, there's some bone here as well. Sorry, should have been on low power. There you can see the nice peripheral rim of bone. Let's see what people are thinking. Exoskeletal osteosarcoma, osseous metaplasia, epithelioid sarcoma. Okay, all considerations. So, quite easy to rule out with immunohistochemistry. Epithelioid sarcoma. Recall that you need an INI1 or SMARC B1. If you have the antibody, it's useful. CD34 is positive in about 60-70% of them, and then of course keratin EMA is also useful in that regard as well. Osseous metaplasia, Boat Maha, the spindle cells, the exoskeletal. Jenish, I personally don't like to use the term exoskeletal osteosarcoma nor the exoskeletal chondrosarcoma. If I see bone and cartilage differentiation, soft tissue, I always ask the question, is this heterologous of something else? Okay, so I always check that out as well. So that's my Irene, myositis ossificans, and then calcified fibromyxoid tumor bit2, and myositis ossificans, Jean. Yeah. So radiology is critical for this. It's very important radiologically, and the X-ray is important because you see the bone on X-ray. The history important as well because there's the history of this left biceps mass 3.6. Again, fascial planes and muscular planes, ill-defined radiology showing this mineralization. We're not seeing too much of a zoning phenomenon here, but you can see areas here which have this sort of peripheral ossification. Okay, and then alternating with some of these areas which look very much like nodular fasciitis. Okay, nodular fasciitis, myxoid areas, spindle, very bland looking, some almost culture-like fibroblasts, almost. Okay, and so that together with the bone and radiology and the history would be correctly labeled as, yes, myositis ossificans. I'm not sure I was able to elicit that Sheena history of trauma. So yeah, my side as well. Just a nice case of this, incorporating both clinical, radiological, and then the morphology as well. Okay, so I said to you, August 5, the next meeting, and if you're in the northern hemisphere, enjoy this heat that we are now having, another heat wave. But I'll see you all August 5, same time, same place. And like I said, if you have friends, colleagues who want to join, just send them Ava's email when you get it, and they can. Yep, you're all welcome. Nice to chat with you guys again. Yeah.